हेलो माय डियर फ्रेंड्स, वेरी गुड इवनिंग टू ऑल। कैसे हैं आप सब? ऑल वेल? ग्रेट। सो वेरी गुड इवनिंग निखिल, वेरी गुड इवनिंग रॉयल, हरि वेंकटेश। So everything is going fine? Great. Yes, Anmol, very good evening. So friends, countdown has already started. Your year will change from 2025 to 2026. Your month will change from December to January. Your date will change. Okay? So overall, 31 days to go. And I'm very sure that you all are preparing very hard for your upcoming examinations. But one thing I must say, that the preparation in these last 31 days is very important. That is the main deciding factor for your result. You may be coming across many hurdles, challenges, could be weather related, could be health related, maybe your personal or family problems. But you have to focus on your goal. You are not going to be distracted by these obstacles. You have to focus on your goal. And the goal is to clear your upcoming 17th January FMGE examination with flying colors, and 200 plus is your mission, and we all are working for that. So boost up your preparation. Mist is coming with 25 most important series. And in continuation of that, today I am here with PSM subject. We will be talking here the 25 most important questions from the clinical important topics. Now this session I had designed in a little bit different way, that we will be having the one question in the form of 4 choices related to one topic. And after that question, we will be having the one-liner rapid fire rounds, maybe as important pointers from that particular topic, and around 10 questions in the form of rapid fire round. So in this session, we will not only talking about 25 questions, but we will be discussing around 280 to 290 questions. Okay. So as this is a rapid fire round for the one-liner pointers, so you are not supposed to write or answer that rapid fire pointer in the chat box, because you'll not be getting the time. I will also not writing the answer. We will be just discussing. And in the end of the session, you will be getting the filled PDF of those pointers and the questions. Okay. So without wasting time, we will be starting with our first question. Now read the question very carefully. Don't be in a hurry to answer the question. Try to get the tricky word, the keyword, the pointer in that question or the buzzword, and then try to answer the question. My first question is, on the diagnosis of bite spot in a 16-month baby, Miku, during the routine health checkup, mother has taken him to hospital for vitamin A supplementation. She had requested doctor to give vitamin A to her elder 3-year-old son, Chiku, also prophylactically, as she knows that its deficiency can cause blindness. Level of prevention is. So we have to find out what is the level of prevention for Miku also, as well as the level of prevention for Chiku. Okay. So I'm waiting for your answer. The level of prevention for Miku and Chiku. Okay. Great. So as Miku is having already bite spots and vitamin A is given for the treatment of this deficiency, so Miku will be having the secondary level prevention as treatment. Okay? So Miko will be not having the primary, so first two choices are out. Miko is having the secondary. Now Chiku is being given vitamin A prophylactically to prevent the deficiency, so it is primary for Chiku. So the correct answer for the Chiku will be the primary level prevention. So the correct answer for this is, that is option number, that is third option, that is option number C. Okay. So we all know that the different levels of preventions we have, that is, if you are trying to prevent the risk factor, it is primordial level prevention. Trying to prevent the disease, that is in presence of the risk factor, is primary level prevention. Trying to early treat a disease, that is secondary level prevention. And trying to manage the complication, that is the tertiary level prevention. Okay. So yes, you all are answering right. Okay. So yes, a great answer for this question from all of you. So now quickly we'll be having some rapid fire pointer round. Okay. So screening is what level of prevention? It is secondary level prevention. Prospective screening, where we are preventing the others by screening of a one person. So it is both primary and the secondary, but a single best answer is primary level prevention, because it is for prevention of others, like we are doing a screening for sex workers, we are doing the screening for immigrants. Okay. Prescriptive screening, it is for the benefit of the self, it is secondary level prevention. The mass chemoprophylaxis, it is primary level prevention. Mass chemotherapy, normally we are using for filariasis. So the main, it is secondary level prevention for treatment of the hidden cases, but because of the treatment we are trying to prevent the others also. So the best answer is both secondary and primary. Single best answer is, it is secondary level prevention. Lifestyle modification, it may be primary, secondary or the tertiary, depending upon where you are trying to do the modification, but a single best answer, if only lifestyle modification is given, it is your primary level prevention. Disability limitation may be primary, secondary or the tertiary, but a single best answer is the secondary level prevention. Early intervention is trying to prevent the complications and the disability. Quit smoking can be again primary, secondary or the tertiary, but single best answer is primary level prevention. Pre or the post exposure rabies prophylaxis, it is to prevent the rabies disease, so it is primary level prevention. The conventional or the emergency contraceptives, again to prevent the pregnancy, so it is your primary level prevention. So this is all about our first topic, that is level of prevention. Now here comes your second question. Mother brings her 4-month baby for a routine vaccination at ICDS centers who had received the previous vaccines as per the schedule till this age. Which vaccine will be given at the marked site? Okay, and which is the marked site? The marked site is in right thigh. Marked site is in right thigh. So which vaccine will be given on this marked site? So I'm waiting for your answer. Yes, very good. Abhir, smallpox, Nitesh, Nikhil, you all are answering quite correct. Excellent, very good. Just try to clap for yourself that yes, it is your option number D. Now here see that how you have to approach this type of the question, that what can be your buzzwords in this question. Number one is age of the baby. The baby is 4-month-old baby, okay? Because the next question, if they can change the age, then answer will change. Next is that this marked site, it is your right thigh. And we know that in a baby of less than 2 years, we are giving intramuscular injection in thigh. So the right thigh, the vaccine which is given, it is the pneumococcal vaccine, okay? And pneumococcal we know, as the baby is 4-month-old baby, less than 2-year baby, we are not using the polysaccharide. So this polysaccharide pneumococcal is out. Why it is not a JE live? Because JE live, it is, although now it is not used in our national program, but JE live, it is given by subcutaneous route, and where it is given in the left shoulder subcutaneous, if it is given. Now JE kill, it is again given by intramuscular, which is now preferred in our national program, is the Kola strain we are using, and this is given in the left thigh, okay? It is given in the left thigh. So the JE live is out, JE killed is out, and pneumococcal polysaccharide is out, okay? Then it is the conjugate left only. Now suppose if my question says that instead of marking on the right thigh, if my mark is given on the left thigh, okay, mark is given on the left thigh, then on the 4-month baby, then what will be your answer? Now the 4-month pay, what we are giving, if a baby is receiving the normal vaccine as per the schedule, means 6 week have already been given, the 10 week is given, now we have to give the 14-week vaccine. So you have to quickly recall what 14-week vaccine we are giving. We are giving the 3rd dose of the pentavalent. So yes, pentavalent will be given intramuscular, will be on this side. Okay. Then another is we are giving the 3rd dose of the OPV, which is given by the oral route. The 3rd dose of rotavirus, which is again given by the oral route. Then we are giving the 2nd dose of the pneumococcal vaccine. It is given in the right thigh. Then we are giving the 2nd dose of IPV. It is given in this right shoulder by intradermal route. Okay. So if my arrow changes from the right thigh to the left thigh, my answer will become as the 3rd dose of pentavalent. Why it is not a JE kill? Because JE we are starting at the 9-month onwards. It is not given at 4 months. Now suppose the arrow is shifted to this left thigh, but my age is changing from the 4-month to the 10-month. Okay, so suppose my age is changing from the 4-month to the 10-month, and the question is same, then arrow has been shifted to the left thigh, then what will be my answer? Now you have to think what vaccine I'll be giving at 9-month-old or the 10-month-old baby. Then all the vaccine between the 9 to 12 months. What are those vaccines? The 1st dose of measles containing vaccine. I know that this is given by subcutaneous route, so it will be given in the right shoulder. Then coming to the Japanese encephalitis 1st dose, then yes, it will be given killed vaccine in the left thigh. Then what else? I will be giving the pneumococcal booster. It will be given on the right thigh intramuscular. Then I'll be giving the vitamin A, which is given by oral route. I'll be giving the 3rd dose of or 3rd fraction of IPV. It will be given into your left deltoid because it is by intradermal route. So by changing the age also from the 4-month to the 10-month, your vaccine will change. By changing the site also from the right to the left, your vaccine will also be changing. So a very, very important buzzwords in these type of the question are, number 1, what is the age of the baby? Number 2nd is that what is the site of the baby? Number 3rd is what is the vaccination received by that baby earlier, okay? Whether he had received the previous vaccines as per the schedule or not, it will be changing your answer. So be very, very careful about these 3 buzzwords because it will change your answer. Now quickly coming to rapid fire rounds are conjugate vaccines used in UIP. What are the conjugate vaccines used in the UIP? The conjugate vaccines are using as pneumococcal conjugate and Hib conjugate. Now what are the live vaccines which are given by oral route in UIP? So what vaccine we are giving by the oral route, that is live, it is OPV and rotavirus, okay, not the vitamin A because that is not a live vaccine. Now live vaccine given by intradermal route in UIP. Now 2 vaccines we are giving by intradermal route, one is BCG, another is it is your IPV. So wherever you are, just try to answer quickly these rapid fire questions, okay? So it will help you in quick revision of the topic. So live vaccine which is given by intradermal route, it is the BCG because it is not your IPV. IPV is a killed vaccine. So the next question, the killed vaccine which is given by intradermal route in UIP, it is your IPV that is given in 3 fractions. The live vaccine which is given by subcutaneous route in UIP. Now the live vaccine which is very important given by subcutaneous route in UIP is your measles containing vaccine MR or MMR. Because now we are not giving the Japanese encephalitis live vaccines in our program, and another vaccine which is given by subcutaneous route live vaccine that is not a part of UIP is your chickenpox and the yellow fever, okay? So they are not your part of UIP, so only one vaccine left is, that is your measles containing vaccine, okay? The toxins given in UIP, the two toxins we are giving, the diphtheria and the tetanus, in the form of the DPT boosters or in the form of pentavalent. Now, polio strain which are causing the vaccine-derived poliovirus. The polio strain which is causing the vaccine-derived poliovirus is P2 strain, and the vaccine strain which is causing the vaccine-associated paralytic polio, that is P3 strain. Okay, and P2 and P3 both has been, it is eradicated, but not the polio disease, because P1 virus is still existing. Okay. Now, VVM used to check for VVM, that is vaccine viral monitor. It is used to check for heat damage of the vaccine. Okay. And stage 1, stage 2 we can use. Stage 3 and stage 4 of the VVM we have to discard. Now, shake test is used to check for. The shake test is used to check for the freeze damage of the vaccine. Okay. Now, mission Indradhanush, it is related to immunization, because parallel word is Abhiyan Indradhanush. And if you can remember, Abhiyan Indradhanush is, it is the change of the bed sheets in as per the ESI Act in the hospitals which are coming under the ESI hospitals. Okay, so जो ESI hospitals occupational health में under the ESI Act or the ASIC, that is ESI Insurance Corporation, under what hospitals are coming, in that hospital daily we are changing the bed sheet as per the color of Indradhanush. Okay, that is Abhiyan Indradhanush. So these are the rapid fire pointers about the vaccine. Coming to our next question, the incorrect about indicators of quality of life. Okay. Incorrect about indicators of quality of life. Okay. Now, be very careful. We have to go with incorrect answer. So great. You all have started answering quite correct, and a big clap for all of you. Great bachas. Okay. Now see, PQLI, that is physical quality of the life index. It is having component as infant mortality rate, yes. Life expectancy at 1 year, yes. And the literacy rate, yes. So this is your true statement. SDI, the life expectancy at birth, yes. The income, yes. Knowledge, yes. So it is also the true statement. PQLI, it is geometric mean. No, PQLI is not calculated by the geometric mean. It is by the arithmetic mean. It is not used for the international comparison. So this is the false statement. The SDI, it is calculated by geometric mean, yes. And it is used for international comparison. So the correct answer that is incorrect is, it is option number C. So yes, quickly we'll go with again our pointers. Now geometric mean, it is used for calculation of HDI. Now geometric mean is calculated, means first of all you have to calculate the indexes. So here I will be writing, because it is just little bit to understand that first of all we have to calculate the life expectancy index, then you have to multiply with the knowledge index, and then you have to multiply with income index. Okay, and then you have to take the cube root of all of these three. Now the next point is that how to calculate the index. Now first of all, the index is calculated, any of the index is calculated as, it is the actual value of that particular country, actual value minus the minimum value globally. It is divided by the maximum value minus the minimum value. So we have to calculate the index for each, like life expectancy index, the knowledge index, and the income index. Then you have to multiply all these and take the cube root. That is what is called as the geometric mean, and it is used for calculation of the HDI. Now arithmetic mean, it is the average of all the three parameters. It is used for PQLI calculation. Now what is the range? Range for PQLI, It is a bigger letter word, as we had to do, we had tried to discuss in our live classes. So life expectancy is starting at a bigger age at 1 year. Okay, so the range is bigger one. 0 to 100 is for the PQLI, and 0 to 1 it is for HDI. Now international comparison के लिए we will be using only HDI value. Now best indicator for burden of the disease, it is your DALY. Okay, best indicator of burden of the disease is DALY. The best indicator of disability, it is HELI, that is health adjusted life expectancy. Intervention increasing the quality of the lifespan will affect. Now, if we are doing an intervention which is increasing the quality of the lifespan, definitely it will be affecting the QALY, that is quality adjusted life years. Positive mortality indicator, that is life expectancy is positive mortality indicator. The direct method of standardization, it is used when we are knowing the age-specific death rate of that particular area, and when we are not using the knowing the age-specific death rate, we are using the indirect method. Okay, so we are using the indirect method of standardization when we are not knowing the age-specific death rate in that particular area, and we are calculating the standardized mortality ratio. So these are our one-liner pointers about the topic, that is the quality of life. Now coming to the next question, and this is again a very, very important topic from where repeatedly question is asked from us in the examination, is to identify the type of epidemiological study. Okay, study started in January 2024, where 500 bike riders using helmet and 500 bike riders not using helmet were followed for 1 year, and frequency of the accidental head injuries in both groups were compared. The correct statement about this study is, so yes, great, Nitesh, Royal, Paneri, you all had started answering correctly, and the answer is option number B, is prospective cohort study. Very good, very good, very good, excellent. Okay, now first go with the question that how you have to look for the study. Now when they had started a study, they started a study in January 2024. Okay, what are the two groups? One group is bike riders using the helmet, so it is an exposure that they are using the helmet. So this is a one group, and that is what is the exposed group. Okay, then 500 bike riders not using the helmet, so this is your non-exposed group. They are following them for 1 year and looking for head injury. So they had started from the 2024 and they are following them for 1 year looking for the outcome, that is accident. So here the two features of the study is already being given. Number one, what is the direction of the study? The direction is forward. Second is, when they started, the outcome was absent, only the exposed or the non-exposed groups were there. So it is your prospective cohort study. And what parameter we are calculating by the prospective cohort study? That is the relative risk. Why it is not a retrospective cohort study? Or I can say कि कब ये retrospective होती अगर statement किस तरह से दिया होता. So it is not a retrospective when it could be a retrospective if a statement is given like this. Listen carefully. Now when they say the study started in year 2025 and they had gone back to collect the record of 2024 and made the two groups who had used the helmet during driving and the other who had not used helmet during the driving, and then analyze the records to look for the accidents happened in this duration. So then it will be a retrospective cohort study. Okay. Now, when it could be a case control study, they will say that they have started a study in 2025 and they have taken a two groups with the head injuries, without the head injuries, and then they had asked their history of helmet use. then it will be your case control study, and the parameter calculated will be odds ratio. When it will be a cross-sectional study, they say that they had went to hospital or in the trauma center and ask about the use of helmet in the patients who were admitted with head injuries. So they come to know that 40% of the patients of the head injuries were only using helmet and the remaining 60% were not using the helmet. So at that particular point, they had analyzed that how many percentage of the population were using helmet in head injury patient. So that is what is a cross-sectional study, and we are calculating the prevalence by cross-sectional study. So like this, the statement will change your study, and you have to see that what type of the study is by looking for either the direction if you can get, or by looking for when they are starting the study, whether the disease is present or not, or whether they are having an exposed or non-exposed. Okay? So if a direction is backward, then it is only the case control study. When the direction is forward, it could be a prospective study or the retrospective study. But prospective they are started when the outcome is absent and they are only going in a forward direction. But in retrospective, they started today, but already outcome is present. They are going little bit back and then analyzing the records and coming to the present time. And it is what is the retrospective cohort study. In both the direction is forward. Then ecological and the cross-sectional we are doing at particular point only. And cross-sectional, how it is different from ecological. Cross-section we are examining the individual person and collecting the information that is based on the primary data. But in ecological, we are collecting the information from another source, that is what is called as secondary data. So this is how that we have to differentiate from cross-sectional and ecological. And how you can identify the RCT or the randomized clinical trial, like when we are starting already the person is having the disease, okay. So one group is that disease with given a new intervention, or the second group is that is the control group. The first was an experimental group and the second was the control group having the disease, but we had either given the placebo tablet or we had given the multivitamin, or we had given an old existing drug, and then we will be going forward to look for the effect. So this is what is your RCT or the randomized clinical trial. So by this you will be able to differentiate between the different type of studies. Okay? Now coming to rapid fire pointers from the epidemiological study. The nested case control study is a type of which is study. The nested case control study is actually a type of the cohort study. Framingham Heart study is a type of which is study. It is again a type of your prospective cohort study, which study is called as incidence study. It is the cohort study is called as incidence study, which study is called as prevalence study. Cross-sectional study is called as prevalence study. Parameters calculated by cohort study is incidence, relative risk, attributable risk, population attributable risk. The risk ratio formula. The risk ratio is same as relative risk. Incidence in exposed by non-exposed. Okay? So don't worry, because some you are just asking about the answers. Don't worry, as I told you that if I will be writing the answer, my session will go a little bit long. I don't want to waste your time. So we will be just discussing the answer here, and in the end of the session, you will be getting the PDF where these all questions will be having their answers filled in that PDF. Don't worry about that. Okay? So risk ratio, it is also known as relative risk. Incidence in exposed by non-exposed, and it is used by clinician to tell the patient about the risk of that risk factor. Okay. Now risk difference, it is also known as attributable risk. Incidence in exposed minus non-exposed by exposed, and this is used by epidemiologists. Then population attributable risk is incidence in total minus non-exposed by the total, and it is helping in making the policies. Okay. Secular trend is which type of the epidemic? The long-term epidemic, it is known as the secular trend. Okay. Like in non-communicable diseases. Secondary waves are seen in which type of epidemic? Secondary waves are seen in common source, multiple exposure type of epidemic like STD transmission due to sex workers. So we are having the multiple waves or multiple curves are there because exposure is in the multiple incubation periods. Okay. Best epidemiological study. Best epidemiological study is meta-analysis. The best analytical study is retrospective cohort study. Okay? The best analytical study is retrospective cohort study. Don't confuse, because meta-analysis is not a part of the analytical group of the studies. Confounding error is best corrected by randomization, where it is correcting both known and unknown confounding error. The known confounding error, it is best corrected by matching. Now, study of choice for rare disease. The study of choice for rare disease, it is the case control study. Now, study of choice for rare disease with expensive investigation is nested case control study. Okay, so these are some of the one-liner pointers, and repeatedly the different questions are asked from this. So we are discussing the keywords, the pointer words, and a question can be framed from that. Okay, so this is a quick revision of the topic epidemiology. Now coming to our next question, that is from topic screening. In a population of 1,000, 50 are hypothyroid. A new screening test says positive result in 70 individuals, while only 35 had the confirmed to have the disease. Calculate the sensitivity of this new screening test. Calculate the sensitivity of this new screening test. So try to solve this question. Okay. So you had started answering as option number B, 50%. Okay, so let us see, because we have to go stepwise, and stepwise means that you have to make the table. Okay, so we have to discuss the 2 by 2 table, and here is that how to fill the values in the table. Okay, the Nitesh says it is C. Okay, so let us see, Nitesh, whether C is correct or it is B is correct. Now, first of all, we know that how to make this table. The vertically, we are writing that how many are having the disease or not having the disease, and in horizontally, what is about the test result, positive or negative. Now, all had started changing their mind, coming to C. So let us see. Now, first is how many is the total population? The total population is 1,000. And out of that, how many are having the disease? 50 is having the disease. So total disease individuals are 50. Okay. So obviously, the remaining 950 are healthy. This is the first step. Now, what they say, a new screening test says the positive result in 70 individuals. So test result is positive total in about the 70 individuals. Okay. Now, out of that, only 35 had confirmed to be having the disease. So out of these 70, the 35 are having the disease. So remaining 35, they don't have the disease, but it is false positive only. Okay. Now, we all know that numbering given, this is the A, this is the B. So you got the value as A and B. You got the value as A plus C as 50. So what is your C value? It is 50 minus 35, that is 15 is your value C. Okay. Now, you got a value D. You got the value as the B plus D, and your D value will be 915. Okay, this is your D value. Now, they had asked is how to calculate the sensitivity, and we know what is the formula for the sensitivity, that is A upon A plus C. A upon A plus C. What is the value A? The A is 35, and what is A plus C? It is 50. So, it is 35 divided by 50 into 100. Okay. So yes, it is your 70%. So yes, you all are very right. It is, the answer is 70%. Yes, beta, it is little bit difficult, but yes, this was asked as one of the PYQ in our the last January exam. Okay, so that's why I put this question, this type of the question. Now, yes, the question is that Nikhil asked that how to make the table in or the chart or table in mind. So yes, beta, because we are not being provided the rough paper and the pen, so you have to make this table in your mind itself. Okay, so you have to go step by step. It might be taking a few seconds more in comparison to the other questions. Okay, that's why we say that other questions which are non-numerical, you can just answer quickly and you can save few of the seconds to solve some type of these difficult numerical questions. Okay, and don't worry, I'll be having a separate YouTube session few days before the exam where I'll be talking only about the numericals, possible numericals to be asked in the upcoming examination, that how to approach for those numericals. Sensitivity and specificity in the short. Sensitivity beta means ability of a test to correctly detect the disease. Okay? So how many are actually having the disease is 50 are hypothyroid, they are having the disease, and this new test is only detecting 35 out of them. So that is 70% is the sensitivity. Now specificity means ability of the test to exclude the disease, means you are absolutely healthy. How many are healthy is 950, and out of that the test declares only 915 as a healthy, and this is 915 by 950 will be your specificity. Okay, then what is the two more questions are asked from this is positive and negative predictive value. Positive predictive value means how many are having the disease after the positive test result. Now positive test is in 70, but actually only 35 is having the disease. So it is A upon A plus B, or 35 by 70, that is 50% is the positive predictive value. Okay, and what is the negative predictive value means that how many are healthy, not having the disease out of the negative test result, that is 915 are not having the disease out of the 930 of your negative test result. So this is what is D upon C plus D will be the negative predictive value. Okay? So you should be knowing the four values here, the sensitivity, specificity, positive and negative predictive value, the four formulas, and you should be learning that how to fill the values in this table, and then definitely you will be coming to your correct answer. ठीक है? Don't worry, आपको लग रहा है, डर लग रहा है, but when question comes in the exam, and with the past experience, I can say that all the students, they had solved numericals correctly. Okay, so don't worry, you will be getting the good marks in the numerical part of the question also. Now quickly coming to pointers of this topic of screening. The change in the prevalence of disease affects which parameter? The prevalence will be affecting predictive value. If prevalence is more, positive predictive value will increase, and if a prevalence is more, the negative predictive value will decrease. The time interval between the first possible diagnosis and the usual time of the disease symptom, it is known as lead time. Lead time. The most important quality of the screening test is sensitivity. Now, diagnostic power of a screening test depends upon the diagnostic power depends upon the three parameters: sensitivity of the test, specificity of the test, and the disease prevalence. High false positive results in a screening test depends upon high false positive result in a test is due to it is either the test is highly sensitive or the disease prevalence is low. Effect on parameters if the test is applied in the series. If you are applying the first test, those positive, we apply the second test, that is what is called as test in the series. The purpose is the result specificity should be high and positive predictive value should be high. Always try to remember with HIV, ELISA and Western blot. Those who are HIV, ELISA positive, then we apply Western blot in only those positive ELISA, and the purpose is that if Western blot is positive, then definitely they should have the disease, means 100% positive predictive value, and those who are healthy, they should be declared negative or they should be out of the race means specificity should be very, very high. To make a test highly specific, keep the cutoff value to upper side or higher side. To make a test highly sensitive, keep the cutoff value to the lower side. Okay. Cost-effective screening test for cancer cervix. It is via and villi. If you have to choose one, via will be better. Cost-effective screening test for cancer breast. It is self-breast examination. The best screening test for cancer cervix. It is Pap smear. Best screening test for cancer breast, depending upon age. Okay, if it is more than 40 years, then it is mammography. The less than 40 years, it is your MRI. If MRI is not in your choice, you can go with ultrasound. Screening test for cancer cervix at the PSC. At the PSC, we are doing the cancer cervix screening by via and villi. Single best answer is a via test. Screening test for the cancer cervix at district hospital level, we are doing with Pap smear. Chemical used for via test is visual inspection after applying the acetic acid, that is 3 to 5% freshly prepared acetic acid. Chemical used for villi test, that is visual inspection after applying the Lugol's iodine. So Lugol's iodine is chemical. Then Kaplan-Meier curve, it is used for the survival analysis. Receiver operator curve, ROC curve is plotted between true positive and false positive. So these are some of the important pointers of topic screening. I can understand बेटा. ये time ऐसा है. You all are working very, very hard. You are getting sometime physically tired, mentally tired, might be feeling अब नहीं हो रहा, अब नहीं हो रहा. इतना कर रहे हैं, in spite of that, sometimes you are not getting the good results. Don't worry बेटा, don't worry. ठीक है? Body will say, stop, just leave, it is enough. But this is not the time to stop. ठीक है? Not the time to stop. You are working so hard for past few years, not only months or days, past few years. So you are not supposed to stop when you are tired. You are only supposed to stop when you are done, and the done is on the 17th of January, when you are done with your paper at 4:30 p.m., then only you have to stop. Okay? So great going on. We are not going to stop till our exam is done. Another important topic from where repeatedly the question is asked is demographic indicators. Now, fertility parameter which is affected by change in age-specific mortality rate in community. Fertility parameter affected by change in age-specific mortality rate in community. I'm waiting for your answers. Okay. The most of you has started answering correctly, and that is option number D, NRR. Okay. Now, just look at these indicators. These are the demographic vital indicators. What is general fertility rate? It is not a glomerular filtration rate, it is general fertility rate, that is total number of the live births per 1,000 reproductive female. So what has been born alive will be a fixed value. It will not be affected if they are dying later in their life. Okay, so GFR is not affected. TFR is total fertility rate, the total number of the children born alive to a lady in her entire reproduction. So what born alive? That number will be constant. It is not affected again by their future mortality rate. So it is not affected. The gross reproduction rate means total number of the girl children born alive to a lady in her entire reproduction. It is also not affected by the mortality later on. But NRR is the total number of the girl children remaining alive till their own reproduction. And yes, it will be affected by mortality. So NRR is a parameter which is affected by mortality in the community. Now quickly coming to the pointers of this topic. The most important demographic parameter, it is NRR or net reproduction rate. So these were the vital indicators. Now what are the demographic population indicators, where the population is constant but their features are changing, like sex ratio, literacy rate, dependency ratio, and the population density. These are population indicators. Now current doubling time of India. The doubling time depends upon the growth rate, and our growth rate is around 1.2% as per the latest SRS September 2025 report, and where our crude birth rate was calculated as 18.4 and the crude death rate was calculated as 6.4. Okay, so our growth rate, it is coming as 1.2%, and we are in the slot of 1 to 1.5%. So the doubling time of India is around 47 to 70 years. Okay, for NRR to 1, the TFR should be 2.1. Now eligible couple register is maintained by multipurpose worker female at sub-center. The sex ratio definition is number of the female per 1,000 male. If only the sex ratio has been mentioned, it means they are talking about at birth. So number of the female per 1,000 male at birth is sex ratio. The denominator in the literacy rate, it is not the total population, it is 7 years or more population. The denominator in the dependency ratio, it is working population, and that is 15 to 65 years. The numerator in the dependency ratio, it is non-working population, less than 15 years and more than 65 years. Now preferred method in census for data collection is the de facto, the de jure. It is the de jure because de facto means you are counted where you were present on the day of the counting. It is not preferred, but the de jure means you are counted as per your permanent residential address. Okay. Identify the phase of the demographic cycle where demographic gap starts increasing and maximum at the end of that phase. Where demographic gap starts increasing and maximum at end of that phase. Which is the phase of demographic cycle. Yes. Very good. A little bit a difficult question, but yes, you all are very right. I'm very happy that you all are going on a very correct track, trying to catch the keywords, trying to getting your answer. जब इतना तो सब आता है, फिर बच्चा क्यों घबरा रहे हो आप लोग? ठीक है, क्यों परेशान हो रहे हो? The everything will be fine. ठीक है? So now quickly revise the phase of the demographic cycle or demographic transition model. This is a very important. It can be asked as an image-based question also, and they can be asking anything about any of the phase. So we are having the 5 phases in this demographic transition model. The first, this purple line, it is showing the birth rate, and the green line, it is showing the death rate. Okay? So in the phase 1 or the stage 1, it is high stationary phase. High stationary means the birth rate is very high, the death rate is very high. To that an extent that birth rate is almost equal to the death rate, population is stationary, and the demographic gap means the difference between the birth rate and the death rate is constant. Then the phase 2 or early expansion phase, okay, when birth rate is very high, but the death starts declining because of the medical facilities. So the demographic gap starts increasing from the beginning of this stage 2, and it is maximum towards the end of the stage 2, okay, and this is known as early expansion phase, and this is what the question is. So population is increasing at a very fast rate. Then what is the stage 3, that is late expansion phase? The birth rate is also declining with the use of contraceptives. The death continues to decline also with medical services, but still birth rate is higher than the death rate. So demographic gap is towards the positive side. Although it starts declining, but still it is towards the positive side. So population is increasing, but at a slower rate. And why this phase is important? Because the India, it is in stage 3 or late expanding phase. Then the stage 4 is a low stationary. When birth rate is very low, the death rate is also very low, almost equal, and the population is stationary. So this is your low stationary phase, okay? And demographic gap is constant. And what happens in the phase 5, or it is the reversal phase, and reversal phase means that the birth rate, it is declining almost to zero. The natural death continues because no one can control the natural death, and population is decreasing. So the demographic gap is reversal, and it is the decline phase. Okay, so all these 5 phases are very, very important, and we should be knowing that about these stage 1, 2, 3, 4, 5, what they are called as: high stationary, early expanding, the late expanding, the low stationary, and the reversal phase. What happens to the birth rate, what happens to the death rate, what happens to the population. They can be pointing an arrow also, that what is this line is representing, like this is a birth rate, what is this line is representing, it is what is the death rate, what is this line is representing, it is the population size. Any question they can be asking from this. Now quickly coming to the pointers of this topic: high birth rate in which phase of the demographic cycle? High birth rate is seen in phase 1 and phase 2, that is the high stationary and early expansion. The stationary population is in which phase of the demographic cycle? The stationary population is in a phase 1 high stationary and the phase 4 low stationary. The current demographic phase of India, it is in the stage 3 or late expansion phase. Ministry which is controlling the census in India, it is Ministry of Home Affairs. The next census in India, it is due in 2027. Okay, and 00R of the 1st of March 2027, we will be counting our population. Now, which survey is called as the dual survey? Sample registration system or survey, SRS survey, it is called as the dual survey. The frequency of the census every 10 years. National Family Health Survey every 5 years. SRS every 6 months it is conducted. Birth and the death registration should be done within. It should be done within 3 weeks or 21 days. The which worker is responsible for birth and the death registration happening in village? It is ASHA worker. Now, base of the population pyramid, it is representing the fertility. Coming to our next question, that is from contraceptives. Again, it is a very, very important topic. Repeatedly, the question is asked from contraception. 28-year female, Mrs. Sharma, reported to medical emergency unit with complaint of high-grade fever with chills and rigors, vomiting and severe pain in lower abdomen. So what the problem she is having? The high-grade fever with chills and rigors, vomiting and pain in lower abdomen. So looking like some infection. On examination, the tachycardia, obviously the pulse rate is high. Temperature 40 degrees Celsius, so obviously a sign of infection. Tenderness in lower abdomen, so looking like as pelvic infection. On examination, per speculum, IUCD thread is visible with pus discharge. So now your diagnosis is clear that intrauterine contraceptive device is in place with pus discharge. Okay. Now, incorrect about the device. Incorrect about the device. Now, please, please, please read the question very carefully. They're asking the incorrect about the device, and this is what an image is: an ultrasound image. This is your a longitudinal scan which is showing the device in the center, and this is a transverse scan which is showing the T-shaped device. Okay. Now, demand the immediate removal of this condition as the PID is present. Okay. So, immediate removal of the device, it is a true statement, beta. It is not an incorrect. Okay. Given device is multi-load. Now, see carefully. Multi-load, if you remember, it is in this shape, and the shape of the device, it is as per the shape of the uterine cavity. While in this picture, what you could see, it is the T-shaped device. So, this is not a multi-load. This is what? It is your copper T. So, this is your copper T. It is not the multi-load, because multi-load wings should be like a uterine cavity size. So, this is the false or incorrect statement. Now, best method for the birth spacing. So, yes, IUCD is supposed to be the best method for the birth spacing. So, it is again a true statement. Now, can be inserted by multi-purpose worker female at the sub-center. Yes, beta, it is also a true statement because the lowest center where we can put the device is sub-center, and this can be inserted by multi-purpose worker also. So, this is also the true statement. So, the question was, what is the incorrect about the device? That is IUCD, which is given in this image. It is the copper T. It is not the multi-load. So, the correct answer here is, that is incorrect, that it is the multi-load 375, because this given device is, it is the T-like structure. So, it is your copper T. Now, coming to the important pointers for this copper T. The best method of the contraceptive for birth spacing, it is birth spacing के लिए it is IUCD. The best method of the contraception for delay in the first baby in recently married couple, it is the oral contraceptive pills. The best method of contraception for young adolescents. No beta, Asha cannot insert the IUCD. ठीक है? Asha cannot insert the IUCD. ठीक है? Now, best method of contraceptive for the young adolescents is the barrier methods and especially condoms. The best time for IUCD insertion when there is no doubt of the pregnancy, that is post-menstrual or the post-abortion or the post-puerperial, that is 6 weeks after delivery. But preferred time in our national program for IUCD insertion is what? It is postpartum IUCD. Within 48 hours of the delivery, we are putting the device. The most common side effect of IUCD insertion is menstrual irregularity. The most important contraindication for IUCD insertion, it is existing pelvic inflammation. Removal method, if IUCD is outside the uterus. If it is outside the uterus, you have to remove with laparoscope. The daily release of LNG, levonorgestrel in Mirena, it is your hormonal IUCD, and it is known as LNG 20, that is 20 microgram of levonorgestrel per day. Can be used up to how many days after sexual exposure as emergency contraceptives? Can be used up till 5 days as emergency contraceptives. The next important contraceptive is oral pills. So again, the questions are expected from this. So beta LNG is not having a daily release of 50 microgram. It is having daily release of 20 microgram. Okay? Now coming to this question, the incorrect about the given contraceptive method. Incorrect about given contraceptive method, and the given contraceptive method is Mala N tablet, that is supplied free of the cost in our national program as oral contraceptives. It is contraindicated. So what they are asking, again see carefully, they are asking the incorrect statement. It is contraindicated in lactating women. Beta, this is a true statement. It is a true. It is contraindicated in a lactating woman. Now, please don't confuse between the correct statement and the incorrect statement. Possibility of the ovarian cancer increases with this use. It is false because ovarian cancer is reduced with this OCPs. Act by ovulation inhibition. Yes, it is acting by ovulation inhibition. It is a true statement. DVT, deep vein thrombosis, is an absolute contraindication. So, it is again a true statement. Okay? So, again beta, try to avoid the silly mistakes on these type of the questions. You have to see the question very carefully. They are asking the correct or they are asking the incorrect. The true, all are true except, all are false except. Be very, very careful. Okay? You have to go with each and every option. You have to just give few seconds to think about that. And here, the option number B, it is incorrect, and that is the answer because they are asking incorrect about the given contraceptive method is. Okay? Now coming to pointers, cancers increases with the use of Mala, and very commonly asked question, increases cancers and the decrease in the cancers. So cancer which is increasing with the use of Mala N is the breast cancer, the ovary cancer, sorry not the ovary, the breast, cervix and the hepatocellular adenomas. The cancers which are reduced means it is protective against the cancers as ovary, endometrium and the colorectal cancer. The composition of the hormonal tablets. it is having combined tablets, means 30 microgram of ethinyl estradiol and 150 microgram of levonorgestrel. Okay. Then composition of iron tablets, it is containing the 19.5 milligram of elemental iron in the form of 60 milligram of ferrous fumarate. Don't confuse the iron folic acid tablet, what we are giving as a prophylaxis under Anemia Mukt Bharat program, or as a prophylaxis in the pregnancy or the lactating woman. It is having 60 milligram of elemental iron in the form of 200 milligram of the ferrous fumarate or 300 milligram of ferrous sulfate salt. Okay, but this is having 19.5 milligram of elemental iron. The name of the non-hormonal oral tablet which you are using in the family planning program. The non-hormonal oral tablet, it is name given as Chaya tablet. Okay. Name of the hormone injections in family planning program or family welfare program is hormonal injection is name given as Antura. The urine pregnancy test kit is known as Nishchay. Okay. Important advice to the couple who has undergone or undergoing the vasectomy surgery, the use of barrier methods for 3 months. The name of implants for permanent contraception. Name of implants for permanent contraception. Okay, I'll wait for a few seconds to just look for your answer for this question. Name of implant which we are using for permanent contraception. Yes, Ayush, you are absolutely right. Sunny, yes, Yasir, absolutely, it is the Assure implant. Great. Number 4, beta, the composition of iron tablet, it is having 19.5 milligram of elemental iron in the form of the 60 milligram of the salt, that is ferrous fumarate. So implant which is given for permanent contraception, it is Assure implant, and if it is for the temporary contraceptive, it is what is Norplant. Okay, so don't confuse in a permanent or the temporary contraceptive. Now preferred emergency contraceptive. Preferred is LNG tablet, single tablet of 1.5 milligram of levonorgestrel to be given within 72 hours. The best emergency contraceptive is IUCD insertion till 5 days of sexual exposure. The non-hormonal long-acting reversible contraceptive. Reversible long-acting means acting for more than 1 menstrual month, okay? And non-hormonal, it is your IUCDs. Hormonal, if we talk about, then hormonal will be your Mirena, which is lasting for 7 to 10 years. It may be the DMPA injection lasting for 3 months, maybe the implants like Norplant 6 for 5 years, Norplant 2 for 3 years, and Implanon or Nexplanon 1 rod implant, it is for 3 years. Okay. This failure in 1200 months of use is for calculation of Pearl index. Now, preferred method of tubectomy in postpartum phase. Just after the delivery, we are doing tubectomy by mini laparotomy. Okay, and the technique what we are using is modified Pomeroy's method. Okay, modified Pomeroy's method. Now, incorrect about population norms. Incorrect about population norms. Beta best emergency contraceptive, we say IUCD insertion. It is IUCD. Okay. Now again, a very important topic, that is healthcare system of India, from where again repeatedly the questions are asked. So first question about the population norms. Urban PSC, it is covering 50,000. Yes, it is the true statement. So again they are asking the incorrect. Urban ASHAs, 1000, it is false, because urban ASHA means the USHA population is from 1000 till 2500, and the single best answer you have to give is the 2000 population. So this is incorrect. You all are answering quite correct. Sub-centers, it is 5000, it is true statement. If nothing has been mentioned about the hilly area or the plain area, so it is 5000. Lab technician, it is posted at PSC and it is covering 10,000. So this is also a true statement. So here the incorrect answer is urban ASHA. Okay. So now quickly try to revise the population coverage of the different centers, different health workers. Now NRHM, National Rural Health Mission, it is covering the population of less than 50,000. National Urban Health Mission, it is applicable if a population is more than 50,000. ASHA worker is 1 per 1,000. USHA worker 1,000 to 2,500, on an average is 2,000. ICDS centers is 400 to 800 per. We are having one ICDS centers. ANM, auxiliary nurse midwives, it is covering 10,000 population. Health and wellness centers, they are replica of sub-centers in the urban areas. It is one for 15,000 to 20,000 population. PSC, it is 30,000 population. Urban PSCs, 50,000 population. CSC, it is 1,20,000 in the plain areas and 80,000 in the hilly area, on an average is 1 lakh. Urban CSCs in metro cities, it is 5 lakh. Urban CSC in non-metro cities, it is 2.5 lakhs. Pharmacist, 10,000. Ophthalmologist is covering 5 lakh population. As per the National Blindness Control Program, we are having ophthalmologists at the secondary vision centers or the service centers. It is covering 5 lakh population. Medical officer posted at PSC, covering 30,000 population. Multipurpose workers, male or female, posted at sub-center, covering 5,000 population. So these are the population norms for various centers, workers. Again, very important, repeatedly had been asked in our previous FMGE questions. Continuously, I am getting repeated messages from loving students. Ki madam, whatever we thought that we will be finishing on this particular day, we are not able to complete. And this is affecting our mental peace. हमारा मोमेंटम डिस्टर्ब हो जाता है, हम थोड़े अपसेट हो जाते हैं कि हम स्लो पढ़ रहे हैं. हमारे कुछ फ्रेंड्स हैं, वो तो फास्ट रीडिंग करते हैं, उनका बहुत जल्दी कवर हो जाता है. विद इन अ गिवन टाइम दे आर एबल टू कंप्लीट देयर desired content what they had decided. Don't worry, beta. Every person is a unique person. They had their own speed of reading, revising and recalling. You are not stand still. ऐसा तो नहीं ना कि आप बिल्कुल नहीं पढ़ रहे हो. You are working, you are studying at your own speed, at your own pace. So go on moving, don't be stand still. Go on progressing, go on reading, go on revising. Okay? Until unless you are moving, you are progressing, then everything is fine. Don't stand still. एक जगह पर रुकना नहीं है, परेशान नहीं होना, चलते चलना है and चलते चलते एक दिन ऐसा भी आएगा जब आप अपनी मंजिल को क्रॉस करके और सफलता की सीढ़ी चढ़ेंगे. So the day will come when you will cross the break point and you will be having the taste of your success. Okay? The next is a health report from a remote village of Rajasthan is confirming high maternal and the neonatal mortality in that area. To control the above situation, a special worker is trained to promote the villagers to register any pregnancy in family to health center, should go for the regular health checkup, use of iron, folic acid and calcium tablets, hospital deliveries and care of the neonates and the infants. The worker is medical officer. It is minimum requirement is MBBS, okay, and that is posted at the PSC. And we are having the specialist, that is the post PG at CSC. So yes, you all are answering quite correct. The worker who is motivating the villagers that they should be registering their pregnancy, motivating them to go for health checkup and use of iron folic acid tablets, promoting for the hospital delivery, it is none other than ASHA workers. Okay, Anganwadi workers are posted at the ICDS centers and they are mainly concerned with the growth monitoring. Okay, then might also giving the vaccination in the village to children, as well as they are also giving health education to the pregnant mothers, lactating mothers or adolescent girls who are coming to the center, distributing the midday meal to children and giving them the non-formal school education. Multi-purpose worker female, they are posted at sub-center, mainly concerned with MCH activities like all antenatal care, natal and the postnatal care, and conducting the deliveries in the center, sub-center, as well as under supervision of the traditional birth attendants, TBA. They are conducting the deliveries in villages also. Then health assistant female, they are posted at PSC, and their function is every week they will be visiting to one sub-center in that area and will be supervising the function of multi-purpose worker females in that area. Now quickly coming to some one-liner pointers. The worker for growth monitoring, it is Anganwadi worker. Worker for ANC or antenatal care or the postnatal care, it is the multi-purpose worker female. Worker of institutional delivery in the periphery. I just want your answer for this question. The worker for institutional delivery in periphery. Whether it will be the TBA or it is multi-purpose worker female. Worker for institutional delivery in periphery. Yes, beta, it is not the TBA because they are saying it is the institutional delivery. Now, TBA is conducting home delivery under the supervision of multipurpose worker, but institution, lowest institution or the center where we can conduct the delivery is sub-center. And at the sub-center, it is by multipurpose worker female. So, yes, you all are very right. Now, worker for IDSP project, Integrated Disease Surveillance Project, it is multi-purpose worker male. Worker for sub-center delivery, we had already talked about, it is multi-purpose worker female. Worker for active malaria surveillance, a very unknown question, it is the multi-purpose worker male. The worker for the well water chlorination in the village, it is again multi-purpose worker male. The worker for home-based newborn care, it is ASHA worker. Worker for home-based care of the young child, it is again ASHA worker. And the number of visits, don't confuse, the home-based newborn care visits depending upon the place of the delivery. If it is a home delivery, the 7 visits. If it is a hospital vaginal delivery, the 6 visits. And if it is a hospital cesarean delivery, the 5 visits are there. And the home-based care of the young child, it is total 5 visits and it doesn't depend upon the place of the delivery or the route of the delivery. Okay? Worker for the motivation to go for nutritional counseling to the ICGS centers on nutrition day, it is ASHA worker. Okay? And another question, where we are having the nutritional counseling, it is in ICDS centers. What is the frequency? It is once in a month. It is once in a month. Next question, as per survey of 1 lakh population in year 2024 in UP, the total live births reported are 5,500 and stillbirth are 500. During the above births, the maternal deaths are as follows: eclampsia 1, road accident 1, rupture uterus 1, PPH 2, ectopic 1, calculate MMR. Calculate MMR. I am waiting for your answer. Calculate MMR. Okay, so you all had started answering as option number C. Now just see, because I also don't know the answer. Okay, so I think a big clap for Imran Khan. You got the hint. Okay, now you are not trapped. We're all are being trapped. Bharat also, a big clap for you. Okay, now Imran and the Bharat, it's big clap for both of you. Okay, now just see carefully. They had given us to calculate the maternal mortality ratio. So the first question, what is the definition of the maternal mortality? It is the maternal death. Okay? It is the maternal death divided by the live births into 1 lakh. So first thing is you should be knowing the formula. Now what is the maternal death is? Will you count eclampsia? Yes. Road accident? No. Rupture uterus? Yes. PPH? Yes. Ectopic? Yes. So how many are there? 1, 2, plus 2, 4 and 1 ectopic. So this is your 5 is the maternal death. Okay? So this is a one catch. Second is where you all were making the mistake. See carefully. The live births reported are 5,500. So already the live births are given and this is the 500 is a stillbirth. They had not given, in this question it is not given as a total birth. Agar total birth 5,500 hota, then you have to minus the 500. They had already given the live births. Okay? So live births are 5,500 into 1 lakh and your answer is 91. Okay? Now just see carefully what can be the mistake. Okay? There could be the 3 mistakes in this and the 3 different answers. The first mistake which some of you were making, you were considering this as the total death. It is not the total deaths, it is the live births. So if you are getting minus of 500, so you may be writing as 5 upon 5,000 into 1 lakh and your answer will be 100. That is a wrong answer. Okay? Now the second mistake what you can be doing is if you are including this road accident in your maternal death, so your total maternal death will be 6. Okay? If it is divided by the total live births into 1 lakh, your answer will be coming as 109, which is also a wrong answer. Now what can be the third mistake where you are doing the mistake at both the points? Means you are calculating the maternal deaths as 6 as well as making the live births as 5,000. So you are making the mistake at the 2 places and your answer will be 120. This is also a wrong answer. Okay? So these are the 3 mistakes you could make and unfortunately all the 3 answers are given in the choices. So these 3 are wrong answers. Only the correct answer is 91. Okay? So yes, it was a trap. So you have to be very concentrate while reading the question. Each and every word is important and that's why we say that your concentration power should be more than 100% while solving any of the question. Okay? Any of the question, because here a single word can change your answer and this single word was the total live births. So I had given here the live births, not the total births. Okay? So total likha tha, usse confuse ho gaye aap log, but it was a live birth. Okay? It is not the total birth. Now quickly revising the one-liner or the pointers from this topic. Number of the maternal deaths per 1 lakh live births, it is called as maternal mortality ratio. Now, number of maternal deaths per 1 lakh reproductive female, it is called as maternal mortality rate. Verbal autopsy is known as rhyme method, whereby verbal interaction you can find out the cause of the death. The most common cause of MMR, it is hemorrhage, and especially the postpartum hemorrhage, and the postnatal period is the most dangerous period. The SDG goal for MMR is to bring down to less than 70 per 1 lakh by 2030. The minimum antenatal and the postnatal visits as per the Government of India is 4 antenatal and 3 postnatal visits. The test which is performed at the sub-center is hemoglobin percentage, blood sugar and urine albumin and sugar. The start of iron folic acid tablet in the pregnancy, if it is prophylactically, then 4th month onwards till the delivery and 6 months after the delivery. And if it is therapeutic, we have to start as early as possible on the diagnosis of anemia, even can be started in first trimester. The health worker which is responsible for MCH care in the periphery is multipurpose worker female. The cash incentive under the JSY scheme to the ASHA in the rural areas, both low performance and high performance state is 600 per delivery, and in urban areas in both low performance and high performance states it is 400 per delivery. Next question is, a 3-year-old child present with some abnormal growth due to past illness. Height to age Z score is minus 2.8 SD. According to the WHO standards, what is the classification? Or this baby will be classified as moderate wasting, severe wasting, moderate stunning and severe stunning. Now the two words are here. First is height to age score. So height to age, it is suggestive of chronic malnutrition, and chronic is, it is not the wasting. So this is out, wasting, wasting. Now we are left with the stunting, whether it is a moderate or severe. Now before answering, just have a look on this growth chart. Just have a look on this growth chart. Now if you remember, we are having the growth chart, that what we are using is the 3 lines. The first line is representing the 50th percentile, or it is median. The second line is representing the minus 2 SD, and the third line is representing minus 3 SD. Okay? So I think now you are changing your answer after looking this growth chart. So any weight within a plus minus of the 2 standard deviation of a mean value or the central tendency parameter is normal in the green zone. So this is the normal value or the normal parameter. Then between the minus 2 to minus 3, it is mild to moderate undernutrition. Okay. And if it is less than minus 3 SD, then it will be a severe undernutrition. Now here, what is the Z score value? Z score value is minus 2.8. So it is coming somewhere between these two, minus 2 and minus 3. So baby is in this yellow zone. So yellow zone is mild to moderate undernutrition. If it is less than minus 3, means it is saying a minus 3.5 or minus 3.8, or it is minus 4, then it will be coming as severe. Okay. So it will be your moderate stunting. It is not the severe stunting. Okay. So I hope it is clear to you now. So first of all, we have to see what a parameter they are talking about. It is height to age. So it is that related to the chronic malnutrition or chronic undernutrition, and it is minus 2.8 SD. It means it is in the yellow zone, that is mild to moderate zone. Okay. So it is your moderate stunting. Now quickly coming to one-liner pointers for this. Best indicator for the growth monitoring in the ICDS centers, we are using, that is weight for age, which is suggestive of both acute and chronic. The low weight for height, it is suggestive of acute malnutrition or it is wasting. The best indicator of maternal nutrition, it is the baby birth weight. The best indicator of MCH care is perinatal mortality. Frequency of health checkup, eye checkup and deworming in the school, it is done every 6 monthly. Referral to the vision center for correction of refractory errors if the vision is less than 6/9. Health and wellness ambassadors in the school, they are the teachers, okay, one male and one female. They are being assigned as health and wellness ambassadors, and the students, they are called as health and wellness messengers. Now, number of the home-based care for the young child, we had already talked about, it is 5 visits by ASHA workers irrespective of the place of the delivery or route of the delivery. The ASH clinics. ASH clinics are adolescent reproductive and the sexual health clinics. They are for adolescent reproductive and sexual health. The main worker of IMCI activity, it is integrated management of neonatal and childhood illness. It is multipurpose worker male. So these are some of the important points related to this topic. If you want to compare the mean hemoglobin percentage of children in the ICDS centers in the age group of 6 months to 6 years before and after giving prophylactic iron folic acid tablets, which test you will be using? Which test you will be using? So here just focus on, they are talking about which data, qualitative or the quantitative data. And the second is you have to look for that how many groups we are comparing, and if it is the same group or it is the different groups, if you are talking about the 2 groups or it is more than 2 groups. So yes, you all had started answering, quite correct. It is your paired student t-test. Now just see carefully. They are talking about comparing the mean hemoglobin. Mean hemoglobin, it is your quantitative variable. Okay, this is one thing. Second is they are comparing the children of the 6 months to 6 years before and after giving the iron folic acid tablets. So how many groups they are comparing? The 2 groups they are comparing, and these are the 2 paired groups or the same groups before and after intervention. So we are using the paired student t-test. Now, if they say that they are comparing the hemoglobin percentage after iron folic acid tablets in the children of 6 months to 6 years and the reproductive female, the 2 different groups, then it will be a unpaired student t-test. If they say they are comparing the children of the 6 months to 6 years, then adolescent, pregnant patient or the lactating patient, the 4 groups they are comparing, then it will be your ANOVA test. Now, if the question says not the mean hemoglobin percentage, they say that anemia percentage if they are comparing. So anemia percentage or prevalence of anemia, if what they are comparing, it will be a qualitative variable. So agar prevalence of anemia they are comparing before and after giving the prophylactic iron, it means they are comparing the qualitative variable, the 2 same groups, it is the sign test we will be using. But if they say that they are comparing the prevalence of anemia after giving the prophylactic iron folic acid for the 3 months in the age group of 6 months to 6 years, then in the adolescents, then in the pregnant patient and the lactating patient, the 4 different groups they are comparing, then we will be using the chi-square test. So in these type of the questions, so you have to first look, it is a quantitative variable or it is a qualitative variable. Second, you have to see if it is a quantitative variable that 2 groups are comparing or the more than 2 groups are comparing. If for 2 groups, we will be using the student t-test, more than 2 groups, we will be using the ANOVA test. If the 2 same groups, we are using a paired t-test, 2 different groups will be using the unpaired t-test. Okay, then if it is a qualitative variable, the 2 groups will be using the 2 paired sign test, and 2 unpaired or more than 2 for the qualitative variable we will be using the chi-square test. Okay, so be very careful about these type of the questions, looking like as the simple questions, but sometimes we may be missing one of the buzzwords in the question. So be very careful about these keywords in the given question. Now quickly coming to pointers of statistic, null hypothesis which is true but it is rejected is type 1 error. Your parents advise true but you are rejecting is a major blunder of your life, type 1 error. The null hypothesis false but it is accepted, your friend is giving the false advice, you are accepting, that is type 2 error. The maximum upper limit of type 1 error, that is alpha value, is 5%. So the significant p value, if it is less than 0.05. So what is p value is the probability of a type 1 error. What you can make is less than 5% or it should be less than 0.05. The best sampling method is the stratified random sampling. The cluster random sampling, it is used for immunization survey, and we are having 13 to 7 clusters. 30 groups and 7 children in each group. The best data presentation method for continuous quantitative data, it is histogram. The trends of events over the time, it is calculated or it is represented by the line chart. The correlation coefficient is calculated by the scattered diagram, and the range of correlation coefficient is -1 to +1. Okay? And here the baseline is 0, and 0 means there is a no association. 0 to -1, it's a negative or protective association. 0 to +1, it is a positive or risky association. Or always remember, the value will never be beyond this range. Okay? But the baseline of the relative risk and the odds ratio is a 1. Okay? So remember this point. Any value as 1, it means no association. Any value more than 1 at the relative risk or the odds ratio is a positive association, risky. Any value less than 1, it is negative association or it is protective. Calculate the percentage of population covered in weight range of 65 to 70 kgs if a mean value is 67.5 kg with a standard deviation of 2.5. Standard deviation of 2.5 kg. Calculate the percentage of population covered in weight range of 65 to 70 kgs. So first of all, you have to see that this weight range is coming in how many of the standard deviation value. Okay. So yes, you all had started answering quite correct. So what is the mean value? Mean value is 67.5. Okay. And what is the standard deviation is 2.5. So 2.5 minus and 2.5 plus. So what is the weight range? That is 65 to 70. That is the weight range of plus minus of the 1 SD. Okay. And we know that plus minus of the 1 SD, it is covering how much of the population? It is 68% population. And this is what the question is, that weight range is 65 to 70 kg, that is coming in plus minus of the 1 SD, which is covering 68% population. Like suppose if a weight range is given as, that is 62.5 to 72.5. So this is how much it is, the -5 or the double of the standard deviation less, and the +5, that is double of the standard deviation. So this is the range of plus minus of the 2 SD, that is covering around 95% population. Okay? And if it is a weight range of, that is around 60 to 75 kgs, it is the weight range of plus minus of the 3 SD, which is covering 99% population. Okay? So either they can be giving you the standard deviation and they can be asking you the range, or they can be giving you the range, they can be asking you the standard deviation or how much is the population covered in that. Any of the direction the question can move. So we have to see what is the mean value, what is the standard deviation, and what is the range, and then we have to give our answer. Okay? Now quickly revising some of the pointers from the statistic. 68% population is covered within plus minus of 1 standard deviation. 95% population is covered within plus minus of 2 standard deviation. 99% is within plus minus of 3 standard deviation. Now relationship between the mean, median and the mode in a normal distribution pattern, all are same. Right skewed deviation, the mean is maximum followed by median and mode. The left skewed deviation, the mean is lowest followed by median and then followed by mode. So highest is mode in the left skewed, highest is mean in right skewed. The central tendency parameter having value more than 1, it is mode value. Now in the presence of outliers, the most affected parameter will be mean. The least affected parameter will be mode, and the preferred parameter is median. The central tendency parameter, which is preferred if it is the metric data, if you can calculate, it is the mean. For the nominal, if you are arranging as per the name, then it is the nominal data ke liye we are having mode. And the ordinal data, if you are arranging in the order, then we are going with the median, the middle value. The value between the two extreme ends is called as range. Deviation of a value from the mean value in terms of standard deviation, it is called as relative deviate or the Z-score. The root mean square deviation, it is standard deviation. So these are the one-liner pointers and had been asked in the previous exams repeatedly, okay. So they can be framing a big question based on these keywords or the pointers. So we have to remember these one-liner pointers, okay. Now, sometimes हमारा ना सेल्फ कॉन्फिडेंस हिल जाता है, हमको लगता है कि यार पता नहीं क्या होगा, इतनी मेहनत तो कर रहे हैं, ठीक है, पता नहीं क्या होगा. So sometimes you are doubting your capabilities, you are just putting a question mark over your hard work and you say that I don't know what will happen, I am working hard from my side. So beta, don't worry, because you are going to have the right time. The God is waiting to give you the gift. Be patient. Be patient, do your work with honesty and leave everything on the God, because God is making you to wait longer, because God is planning to give you bigger blessings, bigger gift, and this will take some time. Okay? If you have to make a small building, it will take a lesser time. But if you have to make a big palace, God is going to gift you the big palace or the castle, then definitely it will take a longer time. Okay? So, believe that yes, you can and definitely you will do. I'm very sure, not 100%, I'm 200% sure that in the upcoming examination, your performance will be beyond the limits. And you all will be going to pass in the upcoming examination. Okay? So don't worry, don't doubt your capability, don't doubt on your efforts, hard work. Just go on doing little more, a few days, 31 days are left for this, and definitely you are going to win this battle. The next question is the guidelines under the given program logo. The given program logo is the logo of your Anemia Mukta Bharat program. So guidelines under the given program logo, it is 5 into 5 into 5 strategy, means 5 beneficiaries, the 5 interventions and 5 institutional mechanisms. It is false, because Anemia Mukta Bharat mein we are having 6 into 6 into 6 strategy, and this is for 5 into 5 into 5 matrix is for RMNCH plus N, that is reproductive, maternal, neonatal, childhood, adolescent and nutrition program. Now frequency of the prophylactic RN is twice weekly in 5 to 59 months of the age. Twice weekly, yes, this is the true statement. It is the true statement. Lactating mother, the red color tablet weekly. The lactating mother may, we are not giving weekly, okay, we are giving daily. So this is your false statement. This is your false statement. Then 14-year adolescent girl, the 14-year adolescent girl, 60 milligram elemental iron, 500 folic acid and blue color tablet, and it is given weekly. So this is a true statement. So the true statement is option number B and option number D. Okay? So these are the true statement, B and D. So your correct answer is, it is answers option C, that is B and D is the correct answer. So little bit a lengthy question, little bit a tricky one, because you have to read each and every word very carefully. So it is your B and D is the correct answer. And these type of the questions with the mix and match choices are very commonly asked in the exam. So we should be knowing everything about this Anemia Mukta Bharat program, where we are having the 6 beneficiaries, 6 interventions and 6 institutional mechanisms. After this, the beneficiaries are very important. And always remember, it is not the 0 to 5 years or 59 months, because 0 to 6 months is exclusive breastfeeding, no prophylactic thing is ended up. So it is 20 milligram of elemental iron and 100 microgram of the folic acid, and this is available in the form of a syrup. So it is available in the form of 1 ml syrup, and the frequency of this is, it is given bi-weekly. twice in a week. Okay, and 5 to 9 years mein it is 45 milligram of iron and 400 microgram of the folic acid. So 5 to 9 years, 10 to 19 years, and 20 to 49 years, it is given weekly. It is given weekly, and the color of the tablet is also different. Then 5 to 9 years mein it is the pink color tablet. 10 to 19 years mein it is the blue color tablet, and 20 to 49 years it is your red color tablet. Okay, the same red color tablet is for the pregnancy and lactation also, but the difference is that it is given daily. Its frequency is daily, and the adult composition of the tablet starts from adolescent age, that is 60 milligram of the iron and 500 microgram of folic acid. Okay, so this is the beneficiary. So we should be knowing this table very carefully, and we are having the 6 interventions. So try to remember that prophylactic iron folic acid we had already talked about. We are doing the deworming every 6 monthly. Then we are doing the testing, treating, and talk. So test, treat, and talk is the strategy for Anemia Mukt Bharat program, as well as we are having now the fortified food with iron. Like salt is fortified with iron, like we had Tata Plus salt, which is having iron. तीन टाइप के हमारे टाटा सॉल्ट्स आ रहे हैं मार्केट में. One is a normal Tata salt, another is the Tata Light, which is having low sodium for hypertensive patients, and the third one is this Tata Plus. Okay, and this is having the fortification with iron. Then 6 institutional mechanisms are from the government side. It is not very important from us in the examination, but yes, beneficiaries and interventions are important. Now coming to important pointers, the most sensitive indicator of the iron deficiency anemia is serum ferritin level. The cutoff level for anemia in pregnancy, if a hemoglobin is less than 11 gram%, the iron requirement in pregnancy is 27 milligram per day. Epidemic dropsy toxin is EDS, BDS is sanguinarine. Endemic ascites toxin, it is AP, it is pyrrolizidine. And epidemic dropsy, it is because of mixing of Argemone mexicana seed oil in mustard seed oil. Endemic ascites is because of intake of Crotodilla seeds mixed with millets. Latherism, the toxin is BOAA, beta oxalyl aminoalanine, because mixing of Lathyrus sativus pulse and yellow pulse, and vitamin C supplementation can be preventing this condition. The most commonly used method of milk pasteurization is flash method or high temperature short time method. Beta, as I told you that filled all these pointers in the form of PDF, you will be getting within few minutes after this session is completed. Okay, so don't worry about that. Okay, you will be having all the answers for these questions. Don't worry, because I know that these questions are very important, so you should be knowing the answers for your revision. Okay. Why I am not writing at this point? Because if I will be writing, then it will take a longer time and the session will go little bit long, which I don't want, because every second of you is very important. So test done before and after pasteurization. The before pasteurization, we are doing the methylene blue test, and after pasteurization, the best test what we are doing is the phosphatase test. Extra calories which is required in pregnancy is plus 350, and if it is asked in a first trimester, then no extra calories is required. Extra calories in the lactation, the first 6 months plus 600 of the basic calories, and the after 6 months it is plus 520. Okay, and we should be knowing the basic calories for a lady. If it is a sedentary worker, then the basic calories is how much? It is 1700 kilocalories. Then you have to add a plus 4 for moderate worker, 2100. Then you have to add that is plus 6, that is 2700 for heavy worker, a female. Okay. Now mother brings her 3-month baby to clinic with complaint of some white spots on eyes. On examination, the doctor finds white spots. This condition could have been prevented by. It could have been prevented by. So I'm waiting for your answers. It is prevented by. Either giving a 3 lakh single dose of vitamin A to mother after delivery, 3 lakh 3 doses to the mother just after delivery. On the schedule is 0, 1 and 14. 50,000 international units, 3 doses, 0, 1 and 14 to the baby. Prophylactic single dose of 3 lakh to mother and the single dose to baby of 50,000 international units. Now you are answering, maximum of you are answering the question number, this question is option number C. Now just listen carefully. This is the trap and where you all are trapped. Now my question is, baby is already having the bite or test spots. Okay? No doubt about that. I am not asking about the treatment. You all are answering about the treatment. Okay? And treatment, if I had asked is, then it is a correct answer, because 0 to 6 month mein, the baby is 3 month and the dose is 50,000 international units, 3 doses. But this is not my question. My question is, this condition could have been prevented. Now this baby, so Imran, now you got my hint. Okay? So this condition could be prevented because in the first 6 months, or rather first 9 months, we are not giving prophylactically vitamin A to the baby. We are giving vitamin A to the mother, because if mother is deficient, then the baby is going to be deficient. This can be prevented by giving the 3 lakh of the vitamin A to the mother just after the delivery. So if we could have given the 3 lakh of the vitamin A single dose to the mother after the delivery, good amount of the vitamin A is flowing through the breast milk to the baby, and this condition could have been prevented. So if my question is that if it is prevented by giving a vitamin A to the mother, if my question is that this is treated, then it is by the 3 doses of 50,000 international units to the baby on the day 1, the day 0, 1 and the 14. Okay? So the 2 questions and the 2 different answers. So be very, very careful about this. Now quickly, just discussing the one-liner pointers. So be very careful in the question whether they're asking about the prophylaxis or they are asking about the treatment and what is the age. Okay? So age, the treatment doses is different and prophylaxis is different, and for the treatment and prophylaxis, obviously the doses are different. So most sensitive test for vitamin A deficiency is the serum retinol level. The most common clinical sign for a screening of the vitamin A deficiency is bite or test spots. The prevalence of the bite or test spots and the night blindness for the major public health problem, the bite or test spots, it should be more than 0.5%, and for the night blindness, it should be more than 1%. Then we say it is a major public health problem. Now, normal fluoride level in the drinking water, it is 0.5 to 0.8 ppm or milligram per liter. Method used for defluoridation of the water, it is the Nalgonda techniques, where we are adding the content as lab, that is lime, alum and bleaching powder. The best indicator of protein quality is the DIS, that is digestible indispensable amino acid score. Amino acid deficient in pulses, PCM, that is methionine. Cereals, that is TLC, we had remembered as the cereal are deficient in lysine, and maize, it is deficient in tryptophan. Acrodermatitis enteropathica is due to the deficiency of the zinc absorption. Okay, pellagra is due to deficiency of the niacin or B3. The most active form of vitamin D is 125 dihydroxycholecalciferol or calcitriol. Identify a vector responsible for the disease for which ASHA worker conducts quarterly fortnight survey, and in doubtful cases, RK39 test is performed in the urine sample and DDT spray is done for vector control. So first of all, we have to see from the given question that they are talking about which disease. And then we have to just look for that disease is caused by which vector. So they are talking about that the worker for the active surveillance of the disease is ASHA. It is conducting the quarterly fortnight survey, and in the doubtful cases RK39 test. So they are talking about it is the Kala Azar or Leishmaniasis. Okay, this is the first part of the question, and yes, you all are answering quite correct. The vector for the Kala Azar is sandfly. Okay, so Kala Azar of the vector for Kala Azar, it is sandfly, and the D is the correct answer. Now, how we can identify the other mosquitoes? If it is sitting parallel to the surface with the dots on the body, it is the Aedes mosquito. Okay, if it is sitting with an angle to the surface, okay, so angle to the surface, so it is your Anopheles mosquito with an angle. Now, if it is sitting parallel to the surface without any dots are there, so this is your Culex mosquito. Okay, and the last one is that is your sandfly. So here the correct answer, that is vector for Leishmaniasis, is sandfly. Now, drug of choice for Leishmaniasis, we know it is liposomal amphotericin B, given as an IV infusion, 10 mg per kg with the body weight. Control of Aedes, Culex and Anopheles. Now, Culex is resting inside the house, female Anopheles after blood meal. So, we have to do indoor residual spray, and for Aedes and the Culex, so Anopheles ke liye indoor residual spray, and for Aedes and Culex we have to do the outdoor fogging. The mosquito control in the urban and the rural areas. Urban areas mein our main focus is on anti-larva measures. In the rural area, our main focus is on anti-adult mosquitoes. The most important quality of the drinking water should be free from pathogenic organisms, and that is E. coli. Softening of water is needed if the hardness level is more than, it is 3 milliequivalent per liter, or it is more than 150 milligram per liter. The most important disinfective agent in chlorination is hypochlorous acid. The instrument used for chlorine demand, it is Horrocks apparatus. Free residual chlorine level in drinking water, it is normal drinking water is 0.5 ppm after contact of 1 hour at pH 7. Now, in the disaster, it is equal or more than 0.7 ppm, and in the swimming pool, it is equal or more than 1 ppm. The most important bacteriological indicator of water contamination is presence of E. coli. The most important air pollutant, it is carbon monoxide. The best indicator of air pollution, sulfur dioxide. The most important content of greenhouse gas effect is carbon dioxide. The most sanitary method for refuse disposal is the sanitary landfilling or controlled tipping, and the land area required is, it is the 1 acre for a waste generated by 10,000 people per year. Preferred method of sewage disposal in the sewage treatment plant is activated sludge process. Heart of sewage treatment plant is aeration tank. Okay. So these are some of the important pointers from topic environment. Now coming to next is a patient with 2 hypopigmented anesthetic patches with no thickened nerve and no muscle weakness in supplied area presented to you. You had diagnosed this patient as leprosy and started giving the pack of the medicine given in the image. And we know that this is the image which is given as the pack of leprosy, 1 month leprosy treatment. Now, correct about this disease. Correct about this disease. Okay? So, be very careful. My question is correct about not this patient, correct about the disease. Case of paucibacillary leprosy, 6-month treatment with the 2 drugs. This is incorrect, false. Now we are not giving the 2 drugs, we are giving 3 drugs. Case of multibacillary, 12-month treatment with the 3 drugs. This is a correct statement because multibacillary mein we are giving the 12-month treatment with the 3 drugs. Undergoing program is the National Leprosy Elimination Program. Now be very careful. leprosy program is not an elimination, it is the eradication program. So this is false statement. Okay. Capsule rifampicin 600 milligram per day for 5 days to the close contact of the newly detected case. No, it is not given for the 5 days. It's only the single dose we are giving. Okay, the single dose we are giving. So this is also the false statement. So the correct statement about the disease, I'm not talking about this patient because this patient is a possibacillary, like 2 hyperpigmented patches, no nerve involvement. So this is a case of possibacillary, but my question is correct about the disease, not about this case. Okay? So that's why the answer is option number B. And this pack is again a very, very important image based question, and they can be putting an arrow in any of the tablet and they can be asking. This is what we are giving the day 1 treatment under supervision. We call the patient to the hospital, and day 1 medicine, this tablet or the capsule are given under supervision by the health worker, and patient should not be having vomiting for at least 30 minutes. This white color tablet is your Dapsone tablet, 100 milligram. These 3 capsules are the clofazimine, total is 300 milligram. The Dapsone tablet is 100 milligram, and this remaining 2 tablets, is the rifampicin tablet, total is 600 milligram. So these 6 tablet and capsule are given on the day 1 under supervision. Then we hand over this pack to relatives or to the patient, and this is a 1-day treatment. And 1-day treatment mein the patient is taking the clofazimine, that is the 50 milligram tablet, and this is the Dapsone tablet, that is 100 milligram daily patient will be taking, and at the end the patient is bringing this empty blister pack, and then next month we are giving the next pack. Okay, so this pack is very important, and how we are giving the tablets is again very, very important. So now quickly go with some of the important one-liner points in this topic. The leprosy is a very, very important topic. So drugs which we are using in the treatment of the leprosy, the day 1 we had already talked about. It is Dapsone 100 milligram, 600 milligram of rifampicin, and 300 milligram of clofazimine under supervision. From the day 2 to day 28, we are using 50 milligram of clofazimine and 100 milligram of Dapsone. Okay. Feature of the POSI and multibacillary leprosy. POSI means skin lesion are 1 to 5, and if it is more than 5, it is multibacillary. No nerve involvement in POSI, and 1 or more nerve involvement is multi. No smear should be positive for AFB, then any of the positive smear for the AFB, it is multibacillary. Okay? So given scenario, you have to identify whether it is a case of possibacillary or it is multibacillary. The loss of sensation in leprosy in the order, first cold goes, then followed by hot, then it is the touch, and finally pain goes. The main infrastructure of leprosy program is the SET center, survey education and the treatment center at the PSC covering 25,000 population. Then incentive given to the patient for the reconstructive surgery is now 12,000 rupees. Inclusion criteria for the post-exposure rabies prophylaxis is that person should be having an exposure of the more than or equal to 20 hours per week, continuously for 3 months or more, to a recently diagnosed new case of the leprosy in the past 1 year. Okay, and what we are giving as single dose of rifampicin 600 milligrams under supervision. The most important epidemiological indicator is annual new case detection rate. The most important operational indicator, it is the grade 2 disability new cases. The target for annual new case detection rate, it should be less than 10 per 1 lakh. The target for grade 2 disability cases at the national level should be less than 1% of the new cases or less than 1 per 10 lakh population. The treatment of a patient on anti-leprosy drugs with Lepra reaction, then continue the anti-leprosy, add steroids. Treatment of leprosy defaulter, not taken the medicine for more than 12 months, then we have to start the medicine with a new pack and a new schedule. Because actually what happens, patient wise boxes are coming directly from the center, and like a POSI mein 6 strips are coming for 6 months, and for multi the 12 strips are coming. So if patient has not taken this strip for more than 12 months, then we will be stopping the previous box and we will be restarting with the new pack. Okay. Adequately treated case of the leprosy means our possibacillary has taken the treatment for 6 months within 9-month duration and multibacillary taken for 12 months within 18-month duration. Now, SAPNA, it is a leprosy musket. APSL, it is a ASHA based surveillance of leprosy suspect. Okay, this is the name given for active surveillance by ASHA, where house to house visits she is giving and trying to find out the suspected case of leprosy. 32-year female patient who had returned to Delhi from Manipur after her 10 days holiday vacation tour, okay, presented to clinic with high-grade fever with chills and rigors, severe headache. On investigation, diagnosed as falciparum malaria, drug of choice. So in these type of the questions, look for what is the diagnosis. It is falciparum. Second is where the person is living or coming from. It is coming from the Manipur, that is the northeast states. And the third is whether if it is a female patient, whether it is pregnant or non-pregnant. Okay, so it is non-pregnant, 32-year female. So you all have started answering very correctly. A big clap for all of you that it is the artemether-lumefantrine combination. Chloroquine in the Plasmodium vivax infection, okay, but not the only chloroquine, so this is out. Chloroquine with primaquine, this is the best answer for the vivax infection. Quinine, we are giving if it is falciparum but in pregnancy first trimester, okay. Now, artemether-lumefantrine combination therapy we are giving in non-pregnant patients, okay, and in the pregnancy if it is in the second or third trimester, okay. So, non-pregnant patient may, if it is in the northeast states, we are giving the ACT AL therapy, and in the other states we are giving ACT SP therapy, okay. And second and third trimester we are giving in the pregnancy diagnosed with falciparum malaria, okay. So now coming to your pointers, again repeatedly the malaria treatment is very commonly asked from us in the exam. So biological cycle in mosquito in malaria. Biological cycle in mosquito, the parasite undergoes both increase in the number and the maturation. So it is your cyclopropagative cycle. The best test for malaria diagnosis is peripheral blood smear, thick and thin smear. Antigen which is detected in the rapid diagnostic test kit for malaria is the HRP2 and LDH. The drug of choice for treatment of vivax infection and malaria is chloroquine with primaquine for 14 days. So, chloroquine for 3 days, primaquine for 14 days. The drug of choice for treatment of the vivax infection in pregnancy. Okay, so normal non-pregnancy may in all the states it is 3 days chloroquine with 14 days primaquine. In the pregnancy, as primaquine is contraindicated, so only we are giving chloroquine for 3 days. The drug of choice for treatment of falciparum malaria, we had already talked about. In the northeast states, it is a artemether-lumefantrine combination. Artemether-lumefantrine daily for 3 days, adding up the day 2 is single dose primaquine. Now, drug of choice for falciparum in other states, that is artesunate, sulfadoxine and pyrimethamine, ACT-SP. So, artesunate we are giving daily for 3 days, then day 1P we are adding sulfadoxine, pyrimethamine single dose, day 2 we are adding the single dose of primaquine, okay. Now, drug of choice for treatment of falciparum malaria in the pregnancy, now we say in the first trimester it is quinine with clindamycin as per the government of India, but WHO says that you can use the artemisinin group of the drugs also, but as we are appearing in the FMGE exam, so your answer in the question that if they ask is what is the drug of choice for falciparum malaria in the first trimester, it is quinine with clindamycin, okay. In the second and third trimester, depending upon their stay, if it is in the northeast states, it is ACT-L therapy, other states ACT-SP therapy. Now, drug of choice for the malaria prophylaxis, it depends upon the duration of the stay. If it is less than 6 weeks, it is the doxycycline, more than 6 weeks, it is chloroquine or mefloquine, because doxy is given daily and chloroquine and mefloquine is given once in a week. How long to continue the chemoprophylaxis after leaving that area, whether taking doxy or taking chloroquine or the mefloquine, it is continued till 4 weeks after leaving that area. Now one more point is the drug of choice for malaria prophylaxis, if it is in pregnancy, irrespective of the duration of the stay, it is only chloroquine. Now indicator for active malaria transmission, it is API, annual parasite incidence. Now indicator for recent malaria transmission is infant parasite rate. The minimum annual blood examination rate should be 10%. The strategy for malaria elimination, we are having the test, treat and track. Those who are positive, we have the first test, those who are positive treat, and you have to track from which area they are coming, because mosquito population will be there, so you have to do the anti-mosquito control in that area. The drug of choice for treatment of filariasis, the 3 drugs, that is IDA, ivermectin, single dose, diethyl carbamazine daily for 12 days, and albendazole single dose. The best test for diagnosis of filariasis is not the peripheral blood smear, it is the membrane filtration test. Reinfection with the new dengue strain, it is more dangerous, leading to dengue hemorrhagic fever or dengue shock, and the dangerous combination is initial V1 infection with the V1 strain followed by V2 strain. Okay. Then biological cycle in filariasis. Filariasis may in mosquito, the microfilarias only undergo the maturation, so it is cyclo-developmental. Okay, and in the dengue, the virus, it is undergoing only increase in the number, so it is propagative. Now best method to prevent dengue, it is to avoid the breeding of the Aedes mosquito, that is primordial level prevention. Now strain of the dengue vaccine, it is quadrivalent live vaccine, that is CYD-TDV is a strain. Again, daily around more than 20 messages I am getting. Ki madam, yesterday I was not able to cover up what I had decided. I was having headache. I was not able to complete my target. And now I am upset that my yesterday has gone. So beta, जो चला गया उसे तो आप नहीं बदल सकते, ठीक है? Yesterday gone means gone forever. That time you cannot take back. So because of the yesterday problem, उसको सोच के आज का दिन बर्बाद नहीं करना है, ठीक है? कल का टाइम तो आप वापस नहीं ला सकते, लेकिन उसके फीडबैक से, उसके इम्पैक्ट से आज का टाइम नहीं खराब करना है. So you are not going to waste the today because of your yesterday some problem or some fault or some defect, whatever you can say. So जैसे कहते हैं ना, छोड़ यार, चल जाने दे, मिट्टी पा. So let's go. Whatever has happened yesterday. You have to focus on today. So take a pledge today that you will not stress over the things which is beyond your control. Like you cannot control what has happened yesterday. हो गया यार, हो गया, ठीक है? उसको लेके परेशान क्यों होना? आपको आज को संभालना है, ठीक है? आज को संभालना है, ठीक है? बेटा, don't worry, you will be getting the PDF in the description box in this video link itself within few minutes once the session is completed, ठीक है? All the filled PDF you will be getting, don't worry, ठीक है? The next is incorrect about the National TB Elimination Program. Incorrect. So the question is, what is incorrect about the TB elimination program? Investigation of the choice in a patient of HIV. It is CB-NAT, it is a true statement. CB-NAT is mandatory before start of ATT, even if the sputum smear is positive. Yes, this is also now compulsory CB-NAT to look for the rifampicin sensitivity, even if the sputum is positive. It is true. MDR, they are resistant to rifampicin, INH and quinolones. They are resistant to rifampicin, INH, but not for the quinolones. If quinolones ko resistant ho gaye, then it becomes a pre-XDR. Okay, so this is your false statement. 3-monthly weekly regimen of INH and rifampicin is given as a TB preventive therapy in HIV patients. This is also a true statement, beta. It is also a true statement. So the false statement, no, beta, you are not getting the point? The question is the incorrect statement, and the incorrect statement is option number C, because MDR, they are resistant to only, that is the rifampicin and INH, not the quinolones. Okay? Okay, so it is a wrong statement. So correct answer for this question, that is incorrect statement, is option number C, not the D, because we are giving the tuberculosis preventive therapy in the HIV patients. Either you can be giving 6 months of INH daily, or you can be giving a 3 monthly weekly regimen of INH and rifampicin, or you are giving the monthly daily of 1 month daily, that is INH and rifampicin. It is a tuberculosis preventive therapy, what we call as the TPT, tuberculosis preventive therapy in the HIV patients we are giving. Okay? Now quickly go with the pointers of TB program. It is a very, very important program. All the sputum samples are checked at designated microscopy centers covering 1 lakh population. Best test for the diagnosis of the latent TB infection is the IGRA test. Okay, interferon gamma release assay, but it is quite expensive. The preferred test for diagnosis of the latent TB infection, now we say it is a CYTB test. Okay, CYTB test, that is like as in a tuberculin-Montague's test, and advantage is that it is specificity is same as an IGRA test, but it is easy to administer, and it is not very expensive also. Okay? So best test, it is the IGRA test, but the preferred test is CYTB test. Okay? Now MDR cases are resistant to, we had already talked about, it is rifampicin and isoniazid. The pre-XDR are resistant to, that is INH, rifampicin and quinolones, and XDR, it is same as pre-XDR, rifampicin, INH, quinolones, and the bedaquiline and bedaquiline or linezolid, any of the group A or category A drugs. Now treatment of the drug sensitive TB, it is what we are giving a 6-month therapy, 2 months intensive phase HRZD 4 drugs, and the 4-month the continuous phase 3 drugs HRE. The treatment of the MDR TB, now the guideline says that if there is no contraindication, we can go with B-PAL-M regime. Okay? Then after start of ATT, the sputum sample become negative within 3 weeks if patient is responding to the drugs. The follow-up schedule for the drug-sensitive TB, it is at 2, 4 and 6 months. We are doing a sputum checkup. The weight bands for the children, because we are having a FDC fixed dose combination therapy. So 6 weight bands are for the children and the 5 are for adults. Then reporting to district hospital for the new tuberculosis cases by the private doctors. Every month we have to report. Okay, so every month we have to report to the district hospital by the private doctors, or they can be making an entry on the NICSHA portal. Okay, the TB surveillance software. The TB surveillance software is what? It is the NICSHA portal. Okay. Now, cash incentive which is given under the NICSHA Poshan Yojana, it is till the end of the therapy. Okay. So, if it is a drug sensitive, it is given for 6 months, and if it is a MDR or XDR cases, then we have to extend further. Now, tuberculosis drug adherence support system, it is called as DOTS 99. Okay, it is called as DOTS 99, where a person has to give the missed call on a toll-free number. So it is tracking that patient is taking the drug or not. If a tuberculosis and HIV is diagnosed together, okay, treatment protocol is first you have to start an ATT for 2 weeks. After that, you have to add the ART. Okay, you have to add an ART. This is to avoid the iris, or that is a complication. Okay, then treatment of the drug sensitive tuberculosis in the pregnancy. The drug are safe what we are using for the drug sensitive. So same protocol as we are using in non-pregnant patient. Okay, and it should be started as soon as possible on diagnosis. Now treatment of MDR, tuberculosis in pregnancy. So here very important is that if it is within the first 24 weeks. So our main priority will be the patient. So best is you can do the MTP and then start an MDR drugs, because the BPALM regime is not safe in pregnancy. And if it is beyond 24 weeks or patient is not willing for termination, even if it is less than 24 weeks, then we have to give the modified treatment till the delivery. And what modification we are doing? We are replacing the ethionamide and the cyclosporin with the PAS, that is para-aminosalicylic acid. Now 4, as for screening of the tuberculosis, is that any history of the cough and fever for more than 2 weeks. Then there is weight loss of more than 10%. Then in the past 3 months, and the 4th one is night sweats. So if these 4 symptoms are there, the patient should be sent for evaluation or for checking for tuberculosis. Now 4 strategic pillar for TB program, that we have to detect, then treat, prevent and build the policy. Okay? So these are, so detect, then treat, then prevent and build. DTPB, it is the 4 strategic pillar of TB program. Now 1% ARI means annual rate of infection. If there is a 1% new infection cases in future, it is equal to 50 sputum positive cases per 1 lakh population. Now can we use BPALM regime in the cases of MDR with HIV? Big yes, because HIV it is not a contraindication, but can we use the BPALM regime in MDR cases with pregnancy? No, because pregnancy it is contraindicated. Pregnancy it is contraindicated. Now JEET, it is a joint efforts between private and government sector for elimination of tuberculosis. Now what is MUM? It is a medicine event reminder monitor. It is a box which is connected through the Bluetooth device with your mobile phone, and it is giving you the reminder if you are not opening the box till the desired time, or once you open, then directly and take out the tablets, directly it is just registering on the NextShare portal that you had opened the box and you had taken the tablet. Okay, so the purpose is that patient should be taking the tablet on a fixed time to avoid the registers of drugs. All are correct about the National AIDS Control Program except. So all are correct about the National AIDS Control Program except. Okay. Then long distance truck drivers are high risk population. Actually, the best answer should be they are the bridge population. Okay, because long distance truck drivers and the male migrants. Okay, so they are the bridge population which are just transferring the infection from the high risk group as the sex workers, then the IV drug addicts, the male having the sex with male. So these are the high risk populations. So it may be plus, minus, or true or false. Both could be there. Then looking for the other statements. Now investigation of the choice in 8-month-old baby to check for mother to child transmission is RT-PCR. Now 8-month baby we are not doing RT-PCR. It is still 6 months. It is now the ELISA test we are doing for. So this is the false statement. Okay? Then ART treatment started as soon as possible after the diagnosis, irrespective of the CD4 count. So yes, this is your true statement. The known case of HIV positive mother taking the ART throughout the pregnancy duration, then the newborn prophylaxis is with the 6 weeks because mother is a low risk, nevirapine only even in the breastfeed mother. So this is also a true statement. So the answer for this that is incorrect is option number B. Okay? Now quickly revising this topic again, it is a very, very important topic for our exam. The Suraksha clinics are giving these services for the sexually transmitted or reproductive tract infections. Now grey kit, it is used for urethral discharge. The green color kit is for the vaginal symptoms of the vaginal discharge. The yellow color kit is lower abdominal pain. And now the brown color kit, because anorectal discharge has been separated from the grey kit, and it is the brown kit for your anorectal discharge. Now surveillance method in the STD, it is to find out the hidden cases, and that is what is sentinel surveillance. Okay, the best test we are doing in the window period, that is the time interval between the entry till first detectable antibodies, it is RT-PCR because ELISA may be negative in this time. The mother to child transmission of HIV without the treatment is 30%, but mother to child transmission possibility if mother is on the treatment and baby is also on the treatment is less than 1%. The best test for HIV confirmation in India, it is Western blot. The first line ART drugs, we are TLD, tenofovir, lamivudine and dolutegravir, which is given as an FDC combination, means a single tablet, it is having all the 3 required drugs. The change in the ART protocol, if a patient is on rifampicin based ATT. Okay, this is a recent INI question that agar patient is on ATT and we have to give the ART also. So in addition to the routine 1 FDC tablet of TLD, add additional 50 milligram of the dolutegravir, and this has to be taken 12 hours after the routine FDC tablet, and this to be continued till 2 weeks after the completion of the ATT treatment. Okay. Now duration of post-exposure ART prophylaxis, it is given for 28 days or 4 weeks. The newborn prophylaxis born to HIV positive mother, again a very important area. Any of a mixed match situation will be there. So newborn prophylaxis born to an HIV positive mother with no ART treatment or had taken a treatment for less than 1 month, then it is a high risk mother. It means a viral load is more than 1000 copies, and here the 2 drugs we will be giving, nevirapine and zidovudine. How long? Depending upon baby is breastfed or not. If a baby is top feed, then 6 weeks only. If a baby is on breastfeed, then minimum 12 weeks, can be extended up to 6 months also. Cotrimoxazole prophylaxis, it is given in HIV exposed infants to prevent the opportunistic infection. It is started from the 6th week of the age till 18 months. Okay. Irrespective of the HIV status, because final status of an HIV yes or no in an exposed infant is at the age of 18 months of the age. Okay. So from the 6 months till 18 months, we are giving cotrimoxazole prophylaxis. Then at the 18 month, if ELISA is positive, then you continue till 5 years, irrespective of the CD4 count. But at 18 months, if ELISA is it is negative, then you can stop this medicine. Okay. The main infrastructure of the HIV program is ICTC centers, integrated counseling and testing centers. Now, what is the strategy? Strategy is prevention is main focus. So prevent, test and treat strategy. And we are having 95, 95, 95, 95, 95, 95 strategy is there. Now, IST clinics, this is the integration of the services for the syphilis, HIV, tuberculosis and hepatitis B and C diagnosis. So at a one center, you can be detecting all these diseases. So if a patient is first coming for tuberculosis, you have to look for HIV and other STDs. And if a patient is coming with the STDs like HIV and other, then you have to look for tuberculosis. Now coming to the next is a 10-month-old child with HIV ELISA positive, reported to subcenter with complaint of fever and breathlessness. On examination by multipurpose worker male, it was reported that respiratory rate is 55 per minute and the presence of chest indrawing. Now correct statement as per IMCI program. So what are the keywords here? The age of the baby is, it is the 10 month. Okay, 10-month baby. Baby is having HIV present. So HIV ELISA is present. Okay. The next is the baby respiratory rate is 55 per minute and there is a presence of chest indrawing. There is presence of chest indrawing. So based on these keywords, we have to classify whether the baby will be a no pneumonia, pneumonia or severe pneumonia. Okay. Now as per the age 10 month, the normal respiratory rate should be less than 50. So it is the respiratory rate is increased. Okay. Now baby is HIV positive. So again it is a high risk case and presence of chest indrawing. So this baby, it is coming in the severe pneumonia category. Severe pneumonia category. Okay. And severe pneumonia category is what? It is antibiotic and immediate referral. And remember that some of you are answering correctly and some is having a little confusion. So it is a severe pneumonia beta because HIV is present. If HIV is absent, then you can say it is a pneumonia. So here the answer is severe pneumonia. So we have to give the antibiotic and referral. But another catch is that it is not the red category. The severe category, it is given as pink category. So it is antibiotic and immediate referral. Now see what can be the further twist in this question. Now if my question says that ELISA it is negative, then my answer becomes a pneumonia case and then it will be the yellow category. Okay? Now if I say the 10-month baby with the respiratory rate no chest indrawing, HIV negative, and if I say the respiratory rate is 45 with only presence of the fever, then it is a no pneumonia because the respiratory rate is normal, then it will be in the green category. So the question can be twisted at any point. So look at for the age, look at for the respiratory rate, look at for the presence of HIV and whether the chest indrawing is present or not. Okay? So what can be the different combination? Just try to see these clinical situations. If a children with the upper respiratory tract symptoms only with the normal respiratory rate, it is a no pneumonia green category. Now if a children of any age with the increased respiratory rate and upper respiratory tract symptom, it is the pneumonia. Okay? Or the yellow category. Now children of more than 2 months with accessory respiratory muscles, it is again a pneumonia. But if a children of more than 2 months with HIV and accessory, it is a severe pneumonia. Now children of less than 2 months with accessory muscles, it is again a severe pneumonia. Okay, may or may not be HIV, but less than 2 months, it is severe pneumonia if there is a accessory muscles are present. Okay, and so these are the different clinical situations, and these are the pointers in that situation. So you have to detect whether it is a no pneumonia, pneumonia, or the severe pneumonia, and you have to manage accordingly. Now vaccine which is given to prevent the pneumonia in our national program, the 3 vaccines we are giving, the pneumococcal vaccine, the Hib vaccine, and indirectly preventing pneumonia is by the measles vaccine. 65-year male who is on the ATT treatment for the past 2 months daily goes to park for a morning walk. One day while walking, the street dog jumped on him, but he had only the minor scratches on his right hand without any blood. So what is the management or what to do next? Now first of all, from this given question you have to identify the grade. Okay, so the grade is what is the type of the wound. It is only the minor scratch hai and without any blood. The minor scratch without any blood. Okay, so this should be the grade 2. Now here the twist is that whether if a patient is on ATT will affect the grade. Answer is no. Because if it is been an HIV and the patient is on the ART, then we know that we have to treat a grade 2 like as a grade 3. But here it is patient is on ATT. Okay, so you are not going to change this grade. This will remain as a grade 2 only. Okay, so grade 2 only. We are not going to treat it as grade 3. Remember this point. Okay, so this was only the twist here. So grade 2 may be no 2 actions, that is local care with vaccine. Okay, so just as reassurance him and nothing to be done. No, the just wash the area and local povidone iodine. No, it is only in the grade 1. Then wash the area and apply the local povidone iodine with the full course of anti-rabies vaccine. So yes, Imran, now you got the hint and this is the correct answer. Okay, then wash the area and apply the local povidone iodine with the full course of the anti-rabies vaccine and local anti-rabies immunoglobulin. So there is no need for immunoglobulin. Okay, so this ATT treatment only has been given to confuse you because ART may treat the grade 2 as grade 3, but in other diseases, we will be treating the as per the grade wise. Okay? So now coming to the pointers of this topic, again a very important topic from our exam. The best test for the rabies diagnosis in the dead person or the animal is demonstration of negri bodies. The best test for the rabies diagnosis in alive person is demonstration of the viral antigen in the biopsy smear you are taken from the nape of the neck by a fluorescent antibody test. The most important site for the brain biopsy. The beta, it is not an RT-PCR for rabies. Okay? Rabies ke liye it is the Niagara bodies. Now, most important site for the brain biopsy is hippocampus first site and cerebellum. The dose of human and animal immunoglobulins. The human is, it is 20 international unit per kg. Animal is 40 international unit per kg. And remember, it is given locally at the wound site. Okay? So, you have to assess, and if a multiple wounds, you have to dilute that total dose with a saline or distilled water, and then you have to locally infiltrate. Never give intramuscular. Pre-exposure vaccination schedule. Before the dog bite, we are vaccinating our high-risk individuals with a 0, 7, 21 or 28 schedule. Post-exposure rabies vaccination schedule in the SN regime, 5 letters in this word, the 5 doses, 0, 3, 7, 14 and 28. Remember, this number is the days when we are giving. It has no connection with the dog bite. When you are starting, given by intramuscular route. The post-exposure vaccination schedule in the Thai Red Cross regime. Thai, the 4-letter words, so 4 doses, 22202, that is the number of the sites. We are giving at the 2 sites, usually the 2 shoulders or the deltoid intradermal. The preferred is Thai Red Cross over the SN regime because better antibody production and lesser doses is required. The vaccination after the re-exposure within 3 months of previous full immunization. Agar previous full immunization within 3 months, only the local care is done. The vaccination, if previous re-exposure, if a previous vaccination is 3 months to 2 years, the booster doses 0, 3, maybe intramuscular or intradermal. And the vaccination, if it is previous vaccination has been taken, re-exposure if it is there, and previous vaccination has been taken more than 2 years back, then the full course of a vaccination. Now, always remember, if a person has taken a previous immunoglobulins or previous vaccination, then again the re-exposure has happened. Never we give the immunoglobulins. Even in a grade 3 bite, we will be only giving the vaccination. Remember this point. And the last question, that is 21-year staff nurse got her posting in the pediatric department where she was supposed to give the antibiotic drugs to children. After drug administration, in which color category she will discard the empty glass vial and syringes with the fixed needle. So empty glass vial, it is going into blue category, and the syringes with the fixed needle, it is going into the yellow category. Okay? So the glass vial will not be going into yellow. The glass vial will be going into the blue category, and the syringes with a fixed needle. So yes, you all are answering quite correct. It will be in white. Okay? So quickly pointers from this topic. The disposal of placenta, it is a non-recyclable infectious waste, yellow, non-chlorinated bag. The disposal of empty blood bag, again yellow, non-chlorinated. Okay? Disposal of the blood-stained gloves, may be blood-stained or not blood-stained, it is just to confuse you. It is in the red, non-chlorinated. Disposal of syringe without the needle, again it is red. The disposal of syringe with the fixed needle, white. Empty glass vial or the broken glass in blue. The sharp blade or knife in white. The method of disposal of yellow content, it is incineration. The first step for disposal of blue, white or the red content is disinfection. Then screw feeder, it is used for the sharp infectious metallic waste. Okay, so this is all for today, and in the last I can say लगे रहो बस, ठीक है, लगे रहो, क्योंकि कोशिश करने वालों की कभी हार नहीं होती है. Now you have to rise. Now from a student you are going to become a class 1, the gazetted officer, ठीक है, because MBBS doctor is considered as a class 1 gazetted officer. So if you have to shine, that you have to burn a little, and you are burning your body, you are burning your mind, you are burning your energy, and definitely you are all going to shine in the upcoming examination. What I can say is 2025 has made you strong, and the coming year 2026 is going to make you happy and successful person in coming your life. And the God is making a list to whom he has to bless now. And in that list, the next name is yours only. So definitely God is going to bless you all and wishing you all the very best for your examination. And thank you from the entire Miss team for having patience and attending this a little bit lengthy, but yes, a very important session. So once again, wishing you all the very best. God bless you all. Bye-bye. Take care. And no doubt, within minutes, you will be getting your filled PDF of all these one-liner pointers in this description link. Okay? So